All right, thank you, everybody. We're glad to have you here today for our hot topics discussion. This particular meeting is kind of exciting because we didn't really have an in-depth chance to hear from our data dissemination award winners. And we also did not have a chance to really hear all of what Kenley had to say in her presentation that had to do with some data work they're doing in Arkansas. So we're going to go ahead and get started today. I want to introduce our first presenter. Cari Frank is from the Center for Improving Value in Healthcare in Colorado. And they received the NATO Data Dissemination Award for their work on CIVHC's Health Equity Analysis Dashboard. In fact, I think I'm just going to go ahead and introduce all of the speakers, and then we can flow from one to the other. Then we'll hear from Daniel McGowan from Virginia Department of Health on Virginia's effort to optimize the user experience of public-facing COVID-19 information. And our final presenter will be Kenley Money from the Arkansas Center for Health Improvement, who will give us a more in-depth discussion on the Arkansas Motor Vehicle Crash Analyses, which was a data deep dive that they did for NHTSA. So we're going to go ahead then and turn the time over to Cari. Go ahead. We're ready for you.
Awesome. Thank you. Well, I apologize. Teams was not being nice to me and wouldn't let me in, so I was a little bit late. I apologize. Let me go ahead and share my screen here. Perhaps it will let me share my screen. Hold on. Sorry, we use Zoom, and so I'm always accustomed to how Zoom operates. Are you guys seeing my presentation here?
Yes, we're seeing it. It's not the view version, but we are seeing it.
Okay, how about now? Is it full screen?
No, it's still the kind of the edit version. But it's okay. If you want to just make it larger, well, we can do that one.
Apologies. I don't know how to fix that. So I'm just going to go over really quickly a little bit more about our tool. And first of all, thank you so much for the award. We were honored and super grateful to be recognized for this particular analysis, which we're super proud of. It's a partnership between us and our Data Better HSRI, who I know a few folks are on the call here today. So we couldn't do it without them. I want to give them huge kudos, but thank you so much for having us and recognizing us for this award. We won it about 10 years ago for our first Shop for Care tool for consumers. So it's thrilling to receive another. So we're here in terms of our mission and vision, just in case you don't know much about CIVHC, we are a nonprofit organization. We're independent and objective, service-oriented, and we're really mission-driven to equip partners and communities in Colorado and across the U.S. with resources, services, and unbiased data, which we'll talk about today, to improve health and healthcare. And our vision is that everyone's going to have the opportunity to be healthy and have access to equitable, affordable, and high quality healthcare. We serve a number of who we call change agents, all with the consumer in the middle. So we support clinicians, hospitals, employers, state agencies, nonprofits, researchers, health plans, you name it, all with the focus on the consumer and making Coloradans healthier. We are the administrator of the Colorado All-Payer Claims Database on behalf of the state. We make that data publicly available, which we'll show you today. And we also offer non-public data to help with specific projects and initiatives that improve health and healthcare. We also have research and evaluation services, which is new for us as of the last year or so. Do a lot of community engagement work and have some program focus areas in advanced care planning and palliative care. The APCD is what feeds parts of the analysis that I'm going to share with you guys today so that you know what's in it. We have over 1 billion claims. We just hit that mark. That's between 2013 and 2022. We do get monthly collections though, but that million mark is what we hit at the end of 2022. It represents over 70% of the covered lives in Colorado. That's from medical only. So it's very robust, over 5.5 million lives. We have some of the self-insured, but as many of you know, we can't collect all of them. We can't mandate to collect them, they're voluntary. And we have over 40 commercial players, Medicaid and Medicare. We don't have the federal programs, VA, TRICARE, Indian Health Services, or uninsured, and some of those ERISA-based. So just a little bit of background on the health equity analysis. As many of you know who are focused in health equity, there is a lot of evidence that shows that actually a lot of a person's health is totally out of their control and based on social factors that are independent of their ability to necessarily get access to good health care. Up to 80% is what the estimate is, and those are social factors such as race, ethnicity, income, education, housing, and transportation. So what we were interested in is how is this impacting, how are those social factors actually impacting healthcare access and the claims and the utilization that we're seeing of services in the Colorado All-Payer Claims database. So as I mentioned, we partnered with our data vendor, Human Services Research Institute, HSRI. It's easier to say HSRI, and developed this health equity analysis tool, really to help policymakers, providers, public health entities, and other communities answer questions like which social determinants might be impacting my neighborhood or community the most, which social determinants are in my neighborhood or my community are most related to poorer health access and might impact health outcomes. And really critical to this, which I think is super important to mention, is that we spent time in 2020 geocoding the ABCD. And again, that was a huge, huge project with our partners at HSRI. Which basically just assigns a latitude and longitude to each person's residence in the ABCD so that we can conduct more specific community level, census tract level information. It allows you to do more of those neighborhood comparisons and bring in the social determinants of health information and overlay it at that community level. Because as many of you are aware, the higher aggregate information that you have, the less you're actually digging into the social factors that may be impacting certain communities. And as I'll show you, community by community, even if it's right next to each other, in the data, you see very different outcomes. So what we looked at is social determinants of health. So we used 5 different measures that were chosen to look at a variety of different potential social factors. We looked at income, which is a percent below poverty line, education, the percent of people in that community without a high school diploma. We looked at employment, the percent of unemployed in that area, and then 2 composite measures. So the first 3 we gathered from the American Community Survey published by the US Census Bureau, but the last 2 are composite measures that came from the Social Vulnerability Index, which is from the CDC. And all of this is at the census tract level that we gathered the external data for. So the housing and transportation was crowded housing and or without a vehicle, people without a vehicle, and then race, ethnicity, language was people of color and or limited English. And then
Cari, can I interrupt really
Yeah.
quickly? If we're supposed to see your slides advancing, we're only seeing the title.
Well, good Lord. Let's see what I can do here. Thank you for saying that.
Now I see social determinants of health and healthcare measures.
Now you see that. Okay.
What looks like slide 9.
Let me just share like all these beautiful slides that I was sharing before. No, I won't go back through it, but are you seeing it now? I won't go full screen because it looked like when I was going full screen, it wasn't working. So
yeah, I'm seeing
I'll leave it
Thank
here.
you.
I'm sorry I'm not showing you the full screen. I'll have to play around with Teams before I do another presentation with you guys. Apologies. So these are the social determinants of health: the income, education, employment, housing, transportation, race, ethnicity, and language. And then we overlaid that information with data that we have in what we call our community dashboard. That's also a publicly available report that we do on an annual basis. And we looked at measures in the community dashboard that looked at access to care, quality of care, cost of care per person per year, and just general utilization. So I am now going to see if I can get this to actually show you guys the actual dashboard itself. Are you seeing the dashboard here on our website? Or are you still seeing the slide?
I see the slide.
Okay, let me see if I can get this to work.
If you want, you can send me the link and I can put it on my screen from here.
Okay. Yeah, if you want to here, am I still sharing? I can stop sharing. It's if you just go to civic.org and I can tell you where to go from there.
Okay.
Thank you. Sorry about this. Challenges. I usually pride myself on being pretty good at sharing screens, but I guess I can't claim that anymore.
Well,
if it makes you feel any better, Teams was being a little tricky, so I don't think it's for me too this morning. So maybe it's not just you.
Well, good. That makes me feel better. Thank you.
all right, how's
I've
that
got
look?
it if you want.
All right, where do I go? Oh, health equity analysis, view the dashboard, maybe?
Yeah. Yeah, you can just view the dashboard. If you're looking for it from the navigation, it's under the Get Data tab, but yeah, that's just as easy. Go for it. And thank you, Jamie. It sounded like you had it up too. So here it is on our webpage. There's some information at the top that just gives some of the background, like I just mentioned, why this is important, and then how to use the report. If you can scroll on the right-hand side, Norm, just start scrolling down a little bit. Whoop. Oh, it went away from it. Can you go back to the Get Data tab?
Get data, okay.
And then just hover over the Get Data. It's easier if you just hover over it. Sorry, at the top, at the very top.
Yeah.
The Get Data at the very top. Like in the top menu bar. Or Jamie can show hers. Oh, thank you. There we go.
Yeah.
There we go.
Thank you. So this is what it looks like. There's information above. There's an infographic that you guys can see high level findings from what we have found just from initial deeper dives into the data, but this is what it looks like. And I don't know, Jamie, if you want to make it any bigger, but it's fine to leave it that way. But on the left-hand side, you will see that you can select the social determinant of health. So if you hover over that, you see the income, education, employment, housing, transportation. Those social determinants are available there. We'll leave it on income, but then if you go underneath that, you can see the different healthcare measures. So we have lack of access to care for children and adults, lack of access to care or children and adolescents, and then for adults separately. We have quality of care, which for us, we chose the no follow-up after ED visit for mental health within 30 days. Cost of care per person per year, utilization of ED visits, and then utilization of potentially preventable. And if you want to go to potentially preventable, Jamie, you can click on that. Thank you. And then the output here is the scatter plot that you see, which are a lot of little dots. All of those represent a census tract in Colorado. So if you don't want to be in that upper right-hand side, you want to be more in the green down below because that's a lower incidence of emergency department visits. But if you look at the R value down in the left-hand corner, that's really what you want to be paying attention to overall. So this is showing the Pearson's correlation coefficient. So the higher that point number up towards 1, the more there is a relationship and the stronger the relationship is. So 0.57 for income and utilization of ED falls into the 0.57, which is according to the scale, a strong relationship between those two, which means as the percent of people living below the poverty line goes up, we tend to see a correlation in number of visits for potentially preventable ED visits. So that is how you would kind of start looking at this. We're looking at statewide right now, but if you see on the left-hand side, you can also select a county of choice. If you don't mind going to Pueblo, because Pueblo's one of the ones in the upper right-hand side, they have a pretty high, potentially preventable ED visit level. And when you switch it, you can actually go to a more detailed census tract view of that county. So you can see down here that there's a lot of variation within even Pueblo County itself. We have some green right there that we're hovering over with a low percentage of people living under the poverty line and a lower percentage of folks that are going to the ED, whereas right next to it, you have a higher percentage. And then you're looking at Pueblo up above too. So you see that R value is now 0.75 and it's higher than the state average. So there's even a stronger relationship between those two things, between income and potentially preventable ED visits for Pueblo County as a whole. We also have put race ethnicity comparisons on the left-hand side, and you can look at each county and Pueblo as a whole. And then we have that information for Colorado too, so that you can see how the specific race and ethnicity compares in those different areas. So that's a high level overview of the report. I don't want to take a ton of time because I know that we have probably messed around with just issues more, but I will tell you what we found is if Jamie, if you scroll up and click on the infographic, we can show folks, if you click at the bottom, you can open it up at the very bottom of it there. Yeah. This is the statewide findings. So what we saw in the social factors where there's a very strong relationship between the preventable ED visits and all of those measures. So what we were just showing you was just income, but income had a very strong correlation with potentially preventable ED visits. So did housing, so did transportation, so did race, ethnicity. We also saw that all of those social factors that we looked at are also very strongly correlated with adults not receiving preventive care. So that's that access to care for adults measure. What we did find that we thought was interesting was that did not have the same impact, or that we didn't see the same correlation between children and adolescents receiving healthcare with any of the social factors. It was a very weak relationship between all social factors and kids not receiving care, which means that they were still getting care regardless of the social factors that they were, their communities were facing. So that could be a testament to our state's Medicaid infrastructure. That could be a testament to adults putting their kids' health ahead of theirs. There's also requirements, obviously, when your kids go to school, that you have to have visits and tests and things like that. So there could be a number of factors playing into that, but we thought that that was kind of interesting that children and adolescents didn't have the same correlation to any of the social factors in terms of getting healthcare. We didn't see any impact on cost of healthcare services per person per year with any of the social factors. And then that quality piece that we looked at, which was the follow-up care after visiting the ED for mental health, that didn't show a very strong relationship there. It was moderate to weakly related to the social factors there. So there's more information on that infographic. There's more information about rural versus urban statewide findings. And county by county, we looked at Denver County and looked at census tracts within Denver County. So there's a lot of information there. I'll stop there just to make sure that you guys have enough time for other folks. And if you have any questions, let me know. Thank you, Jamie, for driving. Appreciate it.
Of course.
She's the mastermind behind all the statistics. So if you have statistic questions, Jamie's your girl, not me. She can describe it much better than I can. But thank you for letting us present. I'll hand it back over. I don't know if I'm handing it back over to Norm or Charles.
I think we'll actually just go to the next presenter, if that's okay. So I think next up is Daniel McGowan with the Virginia Department of Health, if you're ready, Daniel.
Yeah, hey everybody. I'm actually doing this for my supervisor who's currently on holiday. So, but I did help contribute to this, even though it was a team effort. We were looking at a way of optimizing our user experience with public-facing COVID information. And through this, we had to use a lot of different expertise and knowledge through the agency at VDH here at the Department of Health. And we started with work groups. And also including in this work group was really leaning into the accessibility side of how information and data is shared in an agency, especially during a pandemic like COVID. Ultimately, it's not necessarily about how real-time data is shared, like just, shooting it out onto a public-facing website. You also need to make sure that this information is readable and is digestible by population, at least here in Virginia, with some being, having pronounced and unpronounced disabilities, whether it be from vision, whether it be from hearing. Being able to convey that information was really important, and it was kind of one of the linchpins in our unit here at VDH. Where I work in an area called Center for Public Health Informatics, and it was a response to COVID that we even exist now as a unit. We work on the Data Modernization Initiative here in Virginia. So we touch into looking at legacy systems, we touch in looking at capacity building, and finding ways that we can improve processes within an agency. And I'm proud to do this work. I work with really great people. And this project in particular was chosen, again, for a pressing need to enhance our accessibility and optimize user experiences here in Virginia. With COVID, I've had an opportunity to work on different accessibility projects as well as some ADA projects with another state agency. And I know sometimes, finding a way to bridge these gaps between the information you have and being able to present it to a population that, does sometimes need some help with being able to access that information. And COVID was a huge highlight of that. But in our work groups, we had a wider range of expertise. We had people from Office of Information Management. We had people from another informatics office. We had people from DICE, which is our one of our internal surveillance areas. And it ultimately, with that combined knowledge base, we were able to do something really cool. And I think that, we are very thankful for this award. And so yeah, so anyway, one of the key factors was, redesigning our web pages and dashboards and our data sets, and, focusing on clarity and inclusivity was, one of the key driving factors of this. Sorry, I'm looking at my notes. Yeah, so readability and being able to have screen readers was one of the big things that we're working on now with being able to present this and having our dashboards be able to remove barriers of entry, and being able to actually view these real time and have up-to-date information that is available. I wouldn't say close to real time, but as close to real time as we can possibly get. We streamlined menus and navigation systems within our website. This improved our user experience. We're able to actually keep track of how long people stay on pages, and we've noticed over time that it's decreased, which we determined to be a positive because it means that the information that we're putting out is much easier to access. And we were able to integrate some of our data tables and user customized data extraction methods to be able to kind of continue to help facilitate that. And we've also been able to adapt our layouts and designs to meet, 508 compliance and WCAG best practices, and being able to, continue to train our staff that facilitate anything public facing that we present, whether it be a web page or whether it be a data set that we release that makes sure that It's color graded. Make sure if you have graphs that they are readable on anything public facing. But that's currently what I have. I can show off our dashboard though. Let me see.
If you want to take a few minutes and show it, I think that'd be great.
Yeah, so that I'm assuming everybody can see the screen. Anyway, we chose this color and font again, following best practice with 508 and WCAG. We are able to make it readable for everybody, and we have a really good accessibility team that really stays on top of making sure that we continuously audit our public facing web pages, and everything is like I said, graded a certain color for this information. And of course you can move stuff around. But yeah, that's what I got. Any questions?
If you have questions, you can raise your hand, or probably you should be able to take yourself off mute as well. Thank you for sharing this information with us, Daniel, and maybe we can move on and welcome our next presenter, Kenley.
Yeah, thank you.
Hello, everybody. Okay, thank you, Charles. I am going to share my screen. I have a bunch of slides, so we'll go fast. And by. Okay. Is everyone able to see my screen? Arkansas Motor Vehicle Crash Analysis Data Deep Dive? Yes?
Yes, I can see it.
Thank you. Okay. I was asked to give this presentation at NHTSA this year. Big crowd. It was awesome. It describes a policy use of data with an SDOH flavor to it that's a little different than most of our subject areas. APCDs and all the presentations are ripe with cost of care and disease burden, et cetera, and this project uses, I'll just say now, my very favorite data source in all the world, the Arkansas State Police crash data, to give an interesting perspective. And I find what's most fun about this presentation and this data is that everybody can relate to getting a speeding ticket, or I hope you haven't had a crash or an accident, but all of that. This is what we see and touch and feel every day. So folks can relate to it pretty well. Kenley Money here, Director of Information Systems Architecture and the Arkansas APCD Director at the Arkansas Center for Health Improvement. And hereafter, I'm going to call it ACI because there are too many syllables otherwise. Okay. ACI's mission, vision, and values. We are, for all intents and purposes, a nonpartisan health policy shop for the state of Arkansas. Our primary data consumers are the executive branch, the legislature, state agencies, and our data is also made available. Most of our data is made available to external researchers for health and health policy analyses. Unfortunately, the crash data we're about to see is not available for use with the APCD without special permission. So you're going to want it. And I just thought I'd tell you right off. So our priorities, yeah. At the core of our data is this encrypted ID. Some of our data that we receive through legislative mandate only does not have PII. We have a hash ID instead. And so we've this encrypted ID, and we've been able to incorporate this methodology across all our data sources. And it's fairly accurate, really. A lot of data systems use PII to match and find individuals within and across sources. But we find that this encrypted ID, which is the last name and date of birth, works fairly well. Little self-plug there. All right. So ACI has had a lot of experience with crash data over the years. One of our biggest policy successes was the implementation and acceptance of the graduated driver's license. And you can see here in 2009, excuse me, there we go. In 2009, we worked with the state police and others to implement this, and we were able to expand the regulations that govern teen driving laws that had a tiered license structure, restrictions on the number of passengers under 21, and restrictions on time of day when they can be driving. And as a result, we use state police data to track and evaluate impacts of the graduated driver's license regulations. There was an evaluation, and we were recognized by the National Highway Traffic and Safety Association in 2010 for this. But here's really the meat of it. The blue bar, the tall blue bar, is before the graduated driver's license, and the turquoise bar is after. So this policy work with these data, were able to save that many lives and had a significant health impact on teen drivers in Arkansas. Cool stuff with crash data. Some more statistics. I'm going to move forward. So this last year, the state police and the Arkansas Highway Safety Office approached us to help them with a deep dive. Every 3 years, the state police departments and highway departments of states have to do a deep dive on particular subjects to set goals and objectives and measure against it ultimately. And part of this, there's scoping, and then there's a bunch of data collection, data review, and then they build their objectives that are measured over the next 3 years. And so they asked us to do the data deep dive, which is the data component. So we utilized a lot of public data. There's a lot of public data out there on crashes and the reasons for crashes. And we use some in-house data sources as well, which included the crash data. Let me explain what that is, because I'm going to say it a lot. Every year we get a file containing line level information about each crash that happens in Arkansas for that year. And it's the state police crash. We don't, unfortunately, yet get data for city and small town and municipalities, but the state police is involved in almost every major crash, and we get thousands and thousands and thousands. So that means we have a file, and each row represents a crash, and then we have 2 supplemental files, one that link to it, and one is all the vehicles in the crash, and then the third are all the people involved in the crash. So we can drill down quite well to understand what happened in the crash. And so, let's move on. With that in mind, there are data sources, our crash records, some Federal Highway Administration data, NHTSA data, U.S. Census Bureau, and you can see that. Yeah. Have a lot of slides, so I'm going to hurry. So what they were interested in, what the state police and the highway department were interested in, is frequencies and trends in crashes and crash fatalities, risky driving, valuable or vulnerable road users, and disparate outcomes among demographic groups. So by vulnerable road users, we're talking about pedestrians, and we'll talk about that in more detail when we get to it, but this is very compelling about the pedestrians. Crash fatalities. Lots of maps. I don't know how familiar you are with Arkansas, but you can pretty much see where the major highway systems are. So this diagonal line is through here to here is Interstate 30 from Texarkana to Memphis. And then this is Little Rock in the middle. This is I-40 over to, well, I guess 40's there. I should know my highways right. Over to Fort Smith and on. Arkansas roadway fatalities by quarter. And this is all public, but you can see how it ebbs and flows, but it did get higher in the COVID years. Male versus female, male fatalities are significantly higher. I mean, I'm sorry, male, yeah, higher than females. At Nashby, I said women are much better drivers. Anyway, Arkansas roadway fatalities by hour, which is fascinating, and it makes sense. 5 p.m. is very high because that's when people are going home from work. 9 p.m. is interesting when they're coming home from dinner. So the next few maps are I'm going to go relatively fast, but this is Arkansas roadway fatalities by county. This big county here is called Pulaski County. It is the most populated county in the state. The next most populated counties are up here in northwest Arkansas. This is where Fayetteville is, the university, Springdale, Rogers, where Walmart headquarters are, etc. But if you start looking, and there's some statistics, the highest, we're going to look at maps, not tables. The annual average roadway fatality rate per 100,000 residents by county. This is overall. It's interesting here. This county, I forget the name of this county. It's kind of a rural county, but it had such a high hit. The state police and highway department are looking at it to determine, is this ratio because it's a very low populated county and it has a really bad intersection, or what? So they are going to look at that. But if you look over the year, so this is 2016, 2017, 2018, very different. 2019, this county's coming back. 20, there's COVID, and this is interesting because this is down by El Dorado, Arkansas. There's a new big business down here. I think it's an Army contractor of some sort. And then 21 again. So if you look at the maps, you can quickly visualize where the fatality rates are highest. Rural versus urban. It's interesting that isolated is highest at this point, but it gets higher in COVID years, and it has to do with the different lack of participation that the state police had. And then we talk about race. So white, other, Hispanic, Black, and you can see here. And the other is, well, all others Asian, but we have a large Marshallese population in Arkansas. So let's look at race over the years, and there are colors again. There's a bit of a divide that splits the state diagonally. We've not used this type of data as a social determinant of health, but it's interesting nonetheless. Pedestrian fatalities. So what they're looking for here is, this is what I found most interesting, is that there are most places in Arkansas, most towns anymore don't have sidewalks. And they have the state police have an interest in understanding where pedestrians are dying because of the lack of sidewalks. If they have to walk on the road, if it's a small town, they don't have a car, and there are many people in Arkansas who don't have a car, and they have to walk to work or they have to walk to the store. All right, so by race, it's interesting, even pedestrians, the white is still the predominant race. Fatalities by race and by per 100,000. And it was interesting that this dropped in 2019. I don't have a reason why, but it grew in the COVID years. Pedestrian fatalities, here's our map again. And all of these little dots out here and up in here are small towns that don't have sidewalks, or they're dirt roads. People don't have cars. And Little Rock has some, and Northwest Arkansas has some public transportation, but not a lot. Here, I left this in for Little Rock because it's our largest populated city, and you can see the race colors and where they lie. And Northwest Arkansas, which is our fastest growing area, and the race colors and where they lie, and the predominant ones here. And you see more Hispanics here. We have a lot of folks that work in the Tyson plant, the big plants up here. This is some interesting information from the FAR source about day and night when these happen, when pedestrian fatalities happen. It makes sense that they happen mostly in the dark, because if there's no sidewalk, the cars can't see them. Key findings. Pedestrian fatalities were at a 10-year high of 81 in 2020. Areas defined as urban account for 64% of them. In 2021, the rate of fatalities among Black pedestrians was more than double that of white or Hispanic. Most fatalities occur between 6 p.m. and 6 a.m. and Little Rock and Northwest Arkansas are the key areas to target for interventions to reduce pedestrian fatalities. Risky behavior and occupant protection. This is about drinking and driving and seatbelt use. Speeding citations by year and amount. So Troop A, that's Central Arkansas, Little Rock, Pulaski County. Troop L is Northwest Arkansas, which based on the population descriptions we just did makes sense, right? So, and you can see all the rest in the middle, and they went up. These are 100-mile-an-hour plus speeding citations. During the COVID years, they went up. DWI citations went up, though they are coming down ever so. I'll be interested in what this year brings. Reckless driving citations. 2020, it was, I've heard some say it was a free-for-all out there. That's Troop A, so this is all Pulaski County. 16 plus, 16 plus. These are for adults speeding citations. And then roadway fatalities. You can see the distribution here by speeding, which is here. Unknown is here, and then not speeding. Arkansas roadway fatalities, restraint use among vehicle occupants. People do not want to use their seatbelt. And you can see it here. Most of them are none or not applicable. Percentage of occupant fatalities reported not restrained by age across these years. So of course, the younger the person, the less likely fatalities reported the less likely they are to use their seatbelt. Please use your seatbelt. That is the message here. The seatbelt survey of overall rates, and you can see this. And this survey was compiled by the University of Arkansas and asked drivers, "Do you wear your seatbelt?" And they didn't do it during the COVID years. But I'm unsure what actually the end was here, who they actually asked, because the statistics kind of counteract that. Same thing, rural versus urban, and unrestrained fatality rate per 100,000 population by race and ethnicity. So distracted driving, that was seatbelt. We talked about DWIs. Distracted driving is cell phone use, the other things that distract the drivers. You can see by age, by year. The younger generation is very susceptible to that. It's interesting, this year in our legislative session, speaking of this related to the graduated driver's license, there were legislators who wanted to withdraw and negate the graduated driver's license. They call it undue hardship. Now, a teen can still get a hardship license if they need to, which I think doesn't have quite as many restrictions, but it didn't pass. They didn't fail, meaning we still have the graduated driver's license, and these statistics support that. Why we need that. So key findings overall for risky behavior and occupant protection. Citations for 100-mile-an-hour plus speeding nearly doubled from 2019 to 2020, and it increases annually. DWI and reckless driving citations peaked in 2020 and have decreased. The proportion of crashes involving distracted driving was highest among 0 to 17. We saw that. Unrestrained fatality rate per 100,000 population is highest among Black occupants, as opposed to white and Hispanic. And crash fatalities, 56 were unrestrained among 0 to 19. 66% were unrestrained among ages 25 to 30. Next steps. We've compiled all these data. We've delivered it and presented it to the state police and the Arkansas Highway Department, and they are working with their region and other states who did a very similar thing to build their objectives and their measures for the next 3 years. So we will help them explore additional analyses based on their feedback, share findings with state and regional partners. Yes, we're here to share with all the states, and every state's different. Work with stakeholders to identify targeted areas of engagement and education, and continue to develop potential for novel applications of data. So it was fun to use these data, and the results can be incredibly tangible and measurable. So this is who we are. Look us up, achi.net. Charles, that's it.
All right, thank you, Kenley. Thank you, everyone. Do we have any questions for Kenley, or in fact, any of the other presenters? Well, as long as we're at it, go ahead and either raise your hand or just take yourself off mute. I am not seeing anything, but I did want to thank all three of you for your comments and remarks, and for the time that you've taken to share with us some interesting things that are happening out there in the data sharing world. And we're pleased to have you as part of our team.